context. Now, if you look, the dark colors are the imported cases. So if you will, here is the first phase of importation. And most of these imported cases, the black colors, were from mainland China. And then this middle second phase of importation, these were mainly from the Diamond Princess cruise liner. And then finally, this much bigger importation phase, the third phase, the one that we have been in recently, are all the overseas returnees to Hong Kong, most of whom are students in universities and in high schools in Europe and North America. Then you have the unlinked local cases that we cannot find an index link in terms of the transmission chain, and that's the gray intermediate color. And then the lightest one are all secondary infections, okay? So this is what you see for Hong Kong. Now, next, if you actually take all the local cases and their secondaries, okay, then you will find that these are the blue bars. And basically, we take the local cases because that reflects the local transmission dynamics, and then we infer the real-time effective reproductive number from that epicurve, and in fact, we publish it every day, and we update it every day, and we upload it to the dashboard, and you can all follow Hong Kong's progress using this web link here. And basically what you can see is we have actually been bobbing up and down around 1, and if you follow us to now, this is from a week ago, we have now dipped below to 0.7, which is our RT, which is quite reassuring. The other thing that we look very closely at is the symptom onset to reporting interval. So that is basically an indication of how well we're doing quarantine and isolation. So at the beginning, we weren't very good. It took us a week or two to do this. Then we got very good at it, partly because there weren't too many cases. There was a lull in February. And then now we are not doing great, but not too badly. So now it's taking us anywhere between 2-3 days to up to a week to actually isolate our infected cases. Now, so that's Hong Kong for now, and I'd be happy to answer questions on the Hong Kong situation. But just to wrap up the Hong Kong picture, Hong Kong hasn't really had our first wave yet. We're still at the very beginning, and we are holding our own. The RT as of today is 0.7, so it's heading in the right direction. And we've had cases that are mostly imported or their secondaries. And so we can talk about how Hong Kong has been able to hold out for this long period of time, given what's been happening in mainland China firstly, and then in East Asia, and then now in the Western Europe, in the Middle East, as well as in North America. Now, the second half of my opening remarks really goes to, for those places which are actually going through the first wave right now, or for those who are exiting the first wave or completing the first wave, there is a lot of talk about, well, it took a huge amount of courage as well as determination to implement very, very drastic, some would even call draconian measures, to lock down or to suppress the first wave. So what happens when one is coming out of the first wave? What should one do? Now, the premise is, given an R0 of 2 to 2.5, it means that you probably wouldn't see COVID-19 settle down or fade away until at least about half of the world's population will have acquired immunity one way or another. We know, of course, there are only two ways of acquiring immunity. One is by natural infection and recovery, and two is by passive immunization using a vaccine. Now, given that a vaccine is not going to be available until 9 months, 12 months, maybe 18 months from now, and as we know, when you get the first wave, even in very hard-hit places, it doesn't take very long for it to sweep through. So we're probably looking at actually going through these waves of infections, at least 2 or 3 of these, before a vaccine is going to be widely accessible and available and administered to at least half the world's population. And given some shreds of evidence suggesting that even in places that have had a first wave, the seroprevalence is not going to be nearly high enough to avoid a second wave. So that's why we've got this screen that I'm showing you is Imperial report. And this Imperial report basically says, look, how about what they call an adaptive triggering design, okay? So this is the original first big wave. Then the blue is the big suppression, all the things that you do, quarantine, isolation, and physical distancing and border measures. Once you come down, then if you relax, then it comes back, perhaps in a smaller way, and then you suppress again, and then the cycle goes on. Now, this adaptive triggering has had a lot of people discussing and talking. So then Tim Gowers, who was a Fields medalist, he's a mathematics professor at Cambridge. Now, he actually wrote a piece on his blog, and the web link is here. And he did a lot of mathematical formalism. So there is a lot of Greek there. And if you actually read through that mathematics, you will hopefully come to the 5 points that he has made as his summary. And basically, he says that there is nothing to lose and plenty to gain by making the triggers, that is what the threshold may be to trigger between suppression and lift, fairly low, okay? And this is the consequence that the trigger should be set in such a way that the damage from the measures is significantly higher than the damage caused by the disease. Now, he says this sounds paradoxical, but the alternative is to make the disease worse without making the cure any less bad, and there is no point in doing that. And therefore, within reason, the cycles should be kept short, which means that you have to keep on switching between suppression and lift in order to be able to minimize damage. So again, the threshold for switching between suppression and lift should be low, and they should be switched quite frequently such that the cycles are kept short. And there's no point in having more than one measure for the relaxation phase and one for the suppression phase. That is, whatever criterion that you use or criteria you use, they should be the same for suppression and lift. And so if you're interested, read his reasoning. It's a very good read so that you can understand if you really need to turn this theoretical construct into real-life implementation, how you might do that. Now, we are actually publishing a paper in a few hours' time. It will be up on the Lancet website. And part of that paper also addresses the same question. So our whole premise is that, look, if you are at a very low level, you probably want a slow burn. That is, the whole point is not to contain this disease. Containment has failed everywhere. So the best you can do is suppression. And therefore, the big question is, hey, if you are actually doing this, then perhaps you should be considering maintaining an RT of around 1 at a low level so that it becomes a slow burn. If you prematurely relax your suppression, then RT will of course shoot up, and even then you may then try to suppress it and bring RT back down to 1, but you're already at a much higher level in terms of daily disease incidence. So even though you keep the RT at 1, which is the same as here, but if you keep it, then I'm afraid you would be actually at a much higher level, and that's no good. So you would have to spend even extra energy for a much longer period of time to bring it back down to this low level and then keep the RT at 1. And this is basically the mathematical simulation of what I just said theoretically. Okay. Now, okay, so then there is another person, Thomas Puello, who described what the approach that Hong Kong is taking as the hammer and dance. So there is a Twitter feed, and he actually commented on the Hong Kong dance, which is basically commenting on the fact that our RT is bobbing up and down just around 1 at a very low level, which is where you want to be. That's the dance. The hammer is necessary if you actually fail to mitigate and you allow the first wave to actually build. That's when you need a hammer to crush that epi curve or the RT curve before you should then go on this slow burn, this dance. Now, he also went on to say, look, you know, how do you make this dance around 1? And there are various things that you can do or should do. As you go down this, you are looking at more and more drastic measures. And basically, these are things that he thinks should urgently need some quantitative estimate placed against them so that you know which of these policies you should actually implement when you want to push RT from what level to what level. And then, of course, the scientific way of doing it is you put a price tag on each of these policies so that you know what you are trading off against. Now, so let me just sort of summarize the suppression strategies. There are 4 suppression strategies in my mind. There are border restrictions, which basically means that you are reducing the risk of importation, okay? So you are stopping the flow from upstream, reducing passenger volume, and testing all inbound travelers. You're either using point-of-care testing, preferably before they even leave the airport, or high-throughput, timely lab-based methods. So at the moment, Hong Kong just announced today that we are going to hold all inbound passengers at the airport and test them, and they'll have to probably stay there for 4 to 6 hours before the test would come back. And then, if they are negative, they will be required to undergo quarantine at home or in the hotel room for 14 days. That's border restrictions. Then the second set is quarantine and isolation. But quarantine and isolation, remember, depends on 2 things. One is massively scaled testing, and 2 is the concomitant contact tracing. So that's why you need to bring all lab resources to bear to do this, and leveraging the private sector as well. You also need to complement PCR viral shedding testing with serology, especially going to be important as the epidemic rolls on. And of course, you need to have reliable enforcement. Then, social distancing. Now, border restrictions and quarantine and isolation only affect a fraction of the population. They are much more targeted and much more precise strategies. But social distancing affects the entire population, everybody, 100%. It's location-based, mobility and mixing data. That is basically how you do surveillance and really monitor whether social distancing is working or physical distancing. And of course, the ultimate suppression strategy is actually passive immunization, the availability of a safe, effective, and widely available vaccine. This is the last slide. This is a recent paper that we published in Nature Medicine, which basically shows that masks should work. You can see that this is for coronaviruses. This is not COVID-19. These are the 4 human coronaviruses. These are the seasonal viruses. This is flu, and this is rhinovirus. And for coronaviruses, you can see that a mask can actually stop both droplets as well as aerosols. So this is without a mask, this is with a mask, without a mask, with a mask. And for coronaviruses, this is very, very clear evidence. Whereas for flu, you would be able to stop aerosol, but not droplet spread, not as much. And certainly for rhinoviruses, a mask doesn't work. I think that I'll limit my opening remarks to there, and happy to learn from you and to hear your questions. Thank you. Oh, one more thing. Hang on. This is a very important thing. So remember, all of us are in public health, so we care about health protection. Health protection we can do by looking at the real-time reproductive number, and we look at the surge capacity, and ultimately, if you exceed the surge capacity of your health system, you get deaths and you get loss in quality of life. But you have to weigh that against economic preservation. It's not just about the real economy, it's also about real people, employment. And then, of course, the three-way tug of war also is the social consent, where the people are actually going to be willing to adhere to your very drastic physical distancing measures. And even if they are, what is the population emotional well-being? What does it do to them? That separation. Thank you very much. Over.
Thank you very much, Professor. So now we open the floor for questions. I see Iro has a first one, so maybe Iro, you can start. And then if you want to ask a question, please raise your hand, and then we will give you the floor and you can unmute yourself. So Iro, would you like to ask your first question?
Yes.
I see in the chat.
Thank you very much, Professor. It was a great presentation. I would like to stay in your last one before the last slide regarding the use of masks. I've seen this publication, and it is quite reassuring that masks can protect from the coronaviruses. However, there is a great discussion about masks being used by healthy people, and we see a lot of people moving in the streets or doing their shopping using simple surgical masks and gloves. Would you like to comment on that?
Thank you for your question. I think the question about masks is this. I think that there are two things. Number one, of course, a mask is not going to be your only personal protective tool. So I think we need to take things in context. I think that the reason I think that we have to be open, honest, and transparent with the people is because in this day and age, that's the only way to be. People can deal with the truth, people can deal with facts, and they want to think for themselves. I don't think that we should conflate two important sets of issues and then think for them and make a conclusion for them. And the following is what I mean. I think the science is now beginning to give more and more evidence in support of the effectiveness of face masks. And the reason I say that is not only because of that paper that I showed you, which came from our group and was uploaded on the Nature Medicine website last week. There will be another paper also from our group that will be uploaded on the Nature Medicine website next week. And that paper says that we estimate that up to about 40% of all infections were a result of pre-symptomatic transmission. That is, before the index case shows any symptoms. It's usually in the first 2 to 3 days, in the last 2 to 3 days of the incubation period. So 2 to 3 days before first symptoms. Now, that is very important, and that is particularly why, combined with that face mask paper uploaded last week, these two papers together demonstrate, at least to me, that there is a good prima facie case, and at least as a precautionary principle, to show that face mask probably does something. Also, there is a Nature paper that's published by Christoph Fraser's group from Oxford in Nature last week, which also shows exactly what we showed, which is he showed 37% of all infections were pre-symptomatic transmission. And that's in a paper that he published last week in Nature. Then there is a separate piece of experimental evidence from the aerodynamics group at MIT, which shows from an aerodynamic, fluid dynamic perspective, the possible plumes of infected droplets and how far they can spread, and therefore it provides some basic science evidence or physical evidence to show why face masks may work. Hello? Yeah, so I think the science is beginning to emerge in favor of the effectiveness of face masks. Then there is also the common sense issue of, well, even if face masks work, if we have a shortage such that healthcare workers in hospitals, even those who do very high-risk procedures, if they don't have access to face masks, then we should prioritize the limited, scarce supply of face masks for them. That's fine, but the very fact that we use that claim means that we believe that it works. Because if face masks don't work, then if they don't work for common people out in the community, why would they work for healthcare workers in high-risk settings? So I don't think that we should conflate the logistical and practical and feasible issues with the science. I think that the general public could accept that, well, the science tells us that it possibly or even probably works to some degree, and that's why it is important when you are in a high-risk setting in hospitals that you use it. But because we don't have enough, let us all band together and we save these surgical grade masks for hospital workers. And for the rest of us, we will make our own cloth masks, cotton masks, or anything that can use that can be used as a facial shield of sorts. Over.
There is another question in the chat by Riham Basan. What are the latest estimates on the incubation period duration for SARS-CoV-2?
It's very clear. The incubation period has not changed from when we first estimated it. That was the first paper in the New England Journal published online on the 28th or the 29th of January, and that's 5.5 days. So 5.5, 6 days is the average. It can go up to, if you look at the 95th percentile, it can go up to 12 to 14 days, and that really hasn't changed. And the best paper that has the most data on the incubation period is probably the paper by Jaco Wallinger's group in Eurosurveillance, which came out several weeks ago.
Thank you very much. Next question is by Dragan Lausevic. I'm gonna unmute you, and maybe you can ask yourself, Dragan. Hello.
Hello. Can you hear me now?
Yes.
Okay, thank you, Dan. I'm very curious, where do you quarantine contacts or travelers who are arriving in Hong Kong? Do you have some special institutional quarantine or home quarantine? I mean, because of the possible control of infection, if it really appears, and also Does it matter according to your experience? As well as where do you isolate, not quarantine, isolate infected persons with mild symptoms or asymptomatic carriers? What do you suggest, home isolation or some special institutional isolation centers like our colleagues from China suggest that we put all of them in some kind of field hospital or improvised, because it is much easier to control the infection in families?
Well, Hong Kong is lucky. We have not had many cases. We have got a cumulative total of 961 as of this afternoon over the last 3 months. So we have been quite lucky. We have been able to actually hospitalize every single person who tests positive for COVID-19. So the Hong Kong answer is very straightforward. But if and when that number grows to such an extent that we can no longer isolate and treat them in hospitals, then obviously we will have to look at alternative facilities. But I don't think that we would consider any kind of home isolation unless it absolutely grows exponentially and it is completely out of control. And as for your quarantine questions of all our inbound passengers, they are now all issued with a statutory quarantine order at home or in a hotel room. And they are all given wristbands with location function.
Thank you very much. Very useful answer.
We have next question in the chat is by Isabel Noguer. I will unmute you. And after that, we will take, I see some of you have already raised your hand. So after these questions, we will take the ones from people with the hands raised. So Isabel, now it's over to you.
Thank you, Adela. Hello, Adela.
Yes.
Can you hear me?
Yes.
Okay, that's good. Thank you, Professor Leung. I have a question regarding testing policies. Since in Western countries, we have started by testing people with symptomatic or even mild symptomatic situation. What would you recommend regarding the spread of this epidemic in Italy or Spain or other European countries about the testing policies for this kind of epidemic that you already know in your country? What would you recommend in terms of testing?
I think that testing, the testing question is actually very simple. Massively scale up your testing to whatever ceiling that is possible, and think out of the box. You need to massively increase testing at all stages of the epidemic, whether you are very early, like Hong Kong, or you have already passed the first wave. At every stage of the epidemic until a vaccine becomes available, massively scaled testing using private and public sectors and all additional resources you can throw at it. That would be my recommendation. And of course, that has to be buttressed by good contact tracing. And probably you need to at least semi-automate it, because pencil and paper, old style contact tracing, which you do for food poisoning outbreaks, is not going to be good enough for this. Over.
Thank you very much. Useful. We are just in this phase.
Right. Yes.
All the general population.
The next question, Ekaterine Ruatse. Can you hear us, Ekaterine? I see your hand raised. Okay, while waiting, I also see Luz. You also had a question. Can you hear us? Or Sabai, you also have your hand raised. If you you are no longer on mute. If you would like to ask your question. Mariam, I'm going to unmute you as well.
Yeah,
Hello,
thank you. Hello, it's me and Kata. So we have like two questions. One is regarding the lockdown because, as you know, Georgia won't be able to be in a lockdown for a long time. So we're running out of time. So can you tell us what is the stages of lockdown? I mean, releasing it to unlock the lockdown. Where are the stages? And as well, we have the question regarding the patients. I mean, what is do you have the protocol or how do you manage the patients by severity? For example, if the people have mild symptoms, do you let them stay at their place? I mean, at home, and maybe you go and test them, or how do you do that? Yeah. And thank you for this great presentation.
No, not at all. It's a huge privilege, as I said. So as I said, Hong Kong is very lucky so far, and we actually absolutely isolate every single last test positive case. There's no question about that. And then we do contact tracing of all the close contacts, and those people are all quarantined in a separate dedicated facility. They do not get home quarantine. Close contacts of confirmed cases are quarantined in separate facilities, and that they are all quarantined for 14 days, and they get tested on day 12 before they are released back into the community. Over.
Okay, so everyone is getting tested, yeah?
All the close contacts, yes.
All the close contacts, but maybe if there is the mild symptoms, so so all the people go to the special facility, yeah, without any questions.
Yes, everybody's tested, whether or not you get symptoms. Yes.
Okay. And the lockdown. Our question about the lockdown.
We haven't had to lock anything down yet.
And you don't know. Okay, thanks.
Okay. I still see the hands of Ekaterina. Would you like to ask a question or Luz? Julie Bush from Unicri. I'm going to unmute you.
Thank you. Can you hear me?
Yes.
Thank you very much for this very interesting presentation. My question is about the infection. Is there any studies or has it been proven that you can get infected more than once? Over?
It's a very good question, but no, nobody has shown definitively that you can get reinfected quite so soon, at least. And I think that what you may be thinking of is some early Korean data that shows infected people who have recovered, and then in their follow-up, when they get re-swabbed, that they show positive PCRs again. What I haven't seen from that data source is whether they have actually also tested for viral culture, that is virus isolation. Simply getting viral shedding is not very interesting because if you look at one of the papers in Nature, published, I think, 10 days ago by Christian Drosten's group in Berlin, he shows very clearly that viral shedding goes on much longer than when he could actually grow live virus or isolate live virus. So by day 8 or to 10, for most people in his case series who are admittedly mild patients, they will no longer actually be able to grow live virus or culture live virus, even though shedding goes on for another week or two. Over.
Thank you.
Thank you. We have several new questions in the chat. If you still have time, Professor Leung, is that okay? Okay.
Yep.
So Samir Sawala from Palestine, he would like you to comment on whether there are different ways or different stages of the wave at different countries at this time, and also whether you can comment of higher risk groups, like for example, right now the attack rate among Afro-American populations in the States. Over to you.
Sorry, what's the question again? I'm not entirely sure what the question was.
Sur coronavirus con MIT, etc. Lui di Hong Kong. Io conosco.
Hello?
Dr. Leung. Non hai
Hello?
detto?
So the question was whether you can comment about the, for example, higher attack rate right now, it seems in the States for the Afro-American populations.
The African-American population in the US, is that what you're talking about?
Yes, correct.
And the question is why? Is
yes, about the risk factors or different, yeah. Whether you
I don't think there's any evidence for any kind of ethnic or racial susceptibility differences. I think what you may see is simply socioeconomic position confounding, which you would find for any other, for basically any disease in America. You will find the same for cancer. You will find the same for heart disease. You will find the same for stroke. You will find the same for diabetes. And I don't think that this is because of phenotypic differences of COVID-19. I think it is clearly a very well-known socioeconomic gradient issue generally in the US.
Thank you very much. Another question by Dragan. What's the proportion of recovered persons who are positive after 2 consecutive negative tests?
As I said, I think that the original conservative discharge criterion of 2 consecutive negative tests and the absence of symptoms needs to be revised in the light of the fact that, number one, it appears that you will be able to, in at least some cases, find long shedders. But it also appears, at least from the evidence we have so far, that even though you may be able to get positive swabs by PCR, it does not appear that these are infectious because you can't grow them on culture. And thirdly, if you also then look at the serology of patients,
c'est trop fort. Vous
you
deviez
may...
sortir? Ok.
Hello?
Et si Olivier est trop fatigué, reste ici.
Hello? So I think that you also need to look at the serology, and especially for people who have high antibody titers, it is highly, highly, highly unlikely that even though they may shed, that these are actually infectious. Over.
Thank you very much. I'm checking. I don't see any other additional question in the chat. Is there any additional question? Okay, if not, we would like to thank Professor Leung for his time with us. I will give the floor to Isabel Noguer to close the session.
Hello, can you hear me?
Yes.
Yes, okay. First of all, thank you very much, Professor Leung. It has been really we are delighted with your exposition and presentation. And first of all, of course, I would like to thank you for your generosity and availability. As you must know, this is an FTP program funded by the European Commission and led by a consortium with, between Carlos III, the National Public Health Institution, and a foundation called CESAI, and under the leadership of ECDC. ECDC and many colleagues from scientific coordination of the FTP program of ECDC are just participating in this conference. And just to close this session, I would like to do it by addressing a reflection to the audience and to you. The world is facing epidemics and pandemics since the beginning. You have already attended to two important epidemics in Eastern countries. It seems that the European and Western countries didn't expect that COVID rapid spread and its enormous consequences. So this is a reflection and a question. What would you recommend to institutions and professionals involved in public health and preparedness and response training programs to prioritize or to change for the future?
Sorry, I wasn't quite sure what your question was. Can you repeat your question?
Yes, we are an FTP. We are dealing an FTP program for the Mediterranean Black Sea countries, where we participate in different European programs. And well, we are preparing and training epidemiologists for preparedness, alert, and response and emergencies. So what would you recommend regarding the reaction in Europe and other countries face this epidemic? What would you recommend for the trainers of epidemiologists and public health professionals for the future to take into account or to include in our training programs to be more prepared for such kind of pandemics?
Well, I think that you are all really, really super people, because you have already done so much for your own countries. I'm not familiar with your curriculum, so I don't know what you may be already doing and where there may be areas of further improvements. But I would say that the piece of advice I may have for you is to get very good people who have a deep understanding of the laboratory side, especially the phylogenetics, the genomics, the sequencing. These are all going to be ubiquitous in the future. The other aspect is also get people who are very good with numbers, who are quantitative epidemiologists, who actually understand disease models, who understand how to interpret them, and how to use them, how to ask for such data. And I think those are the two areas that typically may not receive as much attention traditionally from FETP programs. Over. Okay.
Thank you very much. Thank you to all participants, all the Medipied family, ECDC, the European Commission, the Joint Research Council that are also connected. Thank you to everyone, and thank you to you, Dr. Leung, for your presentation.
No, thank you very much for the privilege, and very, very, very best wishes and in solidarity with all of you.
Thank you.
Okay, thank you very much to everyone for joining, and especially to Professor Leung. It was an honor. So we will see you in the next webinar. We hope you enjoyed. Bye. Take care and stay healthy.